Right. Sister, did you call me?
Yes, sir. I had a call. 1.5 years old male patient involved in road traffic accident is coming by ambulance.
Okay. Right. Let's activate the trauma call then.
Pediatric Trauma ER. Pediatric Trauma ER. Pediatric Trauma ER.
Thank you, team, for coming in. We've got a trauma call, 1.5-year-old child who's been involved in a road traffic accident and is being brought by an ambulance. So at the top, Vishrut, you're happy to take over the airway?
Yeah, I'll do airway.
You have an airway assistant. Are you happy with that? Whether you will be doing airway assistance and inline stabilization. Then primary survey doctor, you happy with the primary survey initial examination. Sister, you will be helping with the procedures, procedure nurse. Dr. Nikhil, you will be a procedure doctor. Sister, you will help doctor with primary survey. Okay. Sister, can you do the drugs for us? The drugs that we should keep ready is ketamine, fentanyl, rocuronium. We'll also keep tranexamic acid ready. Emergency drugs, so adrenaline, 1 in 10,000, 1 in 100,000 and 3% saline. Okay, we'll assume a weight of 10 kilos. The doses are in your ready reckoner. Okay. Sister, you will be a runner. We have a scribe. Okay, everyone's happy with the job. Anything else to add? Okay, let's move the patient nice and steady.
Pass oxygen to me, please.
Thank you. So let's start with the inline mobilization. Okay, we'll move the patient along with the board on Vishrut's count.
Ready, steady, move.
Vishrut, at the top, do you want to assess the airway?
Can someone please pass the suction?
See on the primary survey, how is the breathing?
Air entry bilaterally equal.
Any external abrasions on chest and abdomen?
No abrasions or any external injuries seen on chest or abdomen.
Okay, cardiovascular, Nikhil, can you check the CRT? And also whilst that, look at the axis, if we can get an axis.
CRT is prolonged, the child is hypovolemic.
Okay, do you want to start for axis? At the top, how are the pupils? How's the GCS?
I'll check the pupils. The right pupil is 4 mm non-reacting. The left pupil is 2 mm non-reacting. I've assessed GCS as well. I'm not getting any verbal response, no eye opening, and there is no motor response even on painful stimulus.
Okay, so a mechanism of injury and low GCS, shall we say 3 of GCS?
Yeah.
So we'll need a CT. So a runner, can you please phone the CT scan and say we need a head and neck CT scan? I think we'll need to intubate this child. Do you want to get ready for the equipment side of things? How are we doing with the IV access?
There is no good peripheral access. I think.
Right, go IO. Good. Okay. Looks like it's bleeding back. Take cross-matching, CBC, blood gas, blood sugar. Right. Now that we have got access, we'll give some drugs. So can we have tranexamic acid, 15 milligram per kilo? Then can we have 3% saline fluid bolus? Numbers at the top: heart rate of 77, blood pressure of 120/90, SATs of 98. I think we'll have to crack on and intubate this child as there are no efforts and GCS is low and we are not far from further deterioration. Before we do that, just a quick recap. So from the top, airway wise, we are going ahead with intubation. We'll do the checklist. Breathing wise, there's no obvious external injuries. We'll get a chest x-ray anyways to see any other injuries. Cardiovascularly, we are a bit unstable at the moment. We have given 3% saline and we have given a fluid bolus with that. We are also going for CT. D wise, our GCS is low. We are going for a CT scan. Can we also inform the neurosurgical team to be aware and also keep the theatres on standby? Exposure wise, we have got IO line which seems to be working just now. If that goes, we'll get another IO. Okay, happy with that? Let's go with the intubation checklist. Right, we are ready from checklist side of things. Over to you.
Do we have drugs ready to go? The child is muscle relaxed.
Okay, ready whenever you are.
Okay, I'll have a look with the laryngoscope. Can I get the laryngoscope, please? I have a good view of the airway. It's a grade 1 airway. Can you please pass the ET tube?
Take your time. Your numbers are steady. Can we connect the entitle and Bain circuit and check if the ET tube is in good position?
The ET is at 12 at the moment.
Okay, let's bag and see. Right, so you've got good chest rise, you've got tube misting, and you have got entitle. Good, wonderful. Let's get a chest x-ray. Right, whilst the x-ray is done, procedure, doctor, do you want to get ready for a central line and arterial line?
Ready, steady, tilt, back.
Now you have to slide the baby ever so slightly to the middle. So brother, back on neck, inline stabilization, and we are going to lift the baby up on Vishrut's call.
Everyone ready? Yes. We go on lift, okay? Ready, steady, lift, back. Good job.
Okay, let's immobilize the head again.
Blocks, please.
Also the runner, can we inform the blood bank that we might need a massive transfusion protocol? So doctor, do you want to do a chest and abdomen ultrasound and a point of care echo to see? Dr. Nikhil, do you want to get set up for a central line and arterial line? Okay, so let's take a gas from the line then. We need to maintain sedation. Drug team, can we make fentanyl infusion and dexmedetomidine infusion as per our protocol, and also rocuronium boluses for the journey? So whilst you get ready for the catheter, why don't we do a quick roll and examine the backside?
Ready, steady, tilt. Ready, steady, back.
Okay, quick recap from the top. Airway wise, we have established an oral tube. We have done an X-ray, which is back. Looks like the tube is in a good position. There's no obvious collection. We are maintaining SATs with bagging as of now. Breathing wise, we have repeated a gas from the line that is cooking. We'll see that gas and act accordingly. Cardiovascularly, we are holding our blood pressure. The heart rate seems to have come up to 90s and 100s and seems to have some sort of hemodynamic stability. Medications wise, we are currently on fentanyl of 4, dexmedetomidine of 0.7. We'll adjust that as per the response and we'll use rocuronium boluses as and when needed. Exposure wise, we have a central line triple lumen, we have an arterial line which shows good trace, and fluids wise we are on 2/3 maintenance, 0.9 DNS, and we can adjust that later on based on how the gas comes back. We have an OG tube which is on free drainage, and infection wise from a central line, can we take a culture and give 1 dose of cefuroxime whilst this urinary catheter is being done? Okay, so we have used the transfer checklist. We'll start moving now. Everyone's happy?